Alright guys, this is Dr. Manish Chhabra, your ophthalmology educator. Now I had recently conducted one voting on my ophthalmology by Dr. Manish Chhabra Telegram group, where I had given two options of the topics which you want me to discuss. So this internuclear ophthalmoplegia received the maximum number of votes, in view of which I am doing this short, crisp and concise video. And of course, like I always do, I am going to show you the real patient of INO as well. Now, my vision of bringing this EyeCoach app to all of you is that I want to make ophthalmology one of the most easy topics, because what happens is during our graduation we are not much exposed to this beautiful subject of ophthalmology. Yes, it is beautiful, yes, of course. So what happens is we tend to procrastinate while reading ophthalmology, because what we see is just the sclera, the cornea, and we don't get to see what is happening on the retina, what is happening inside the vitreous. So we don't usually develop the interest. So what I have done is, in EyeCoach app, so there are different courses in which I have included the real patient videos, so that you have a feeling of sitting with me in my OPD. And we will also be going in main operation theater, minor operation theater. We'll be doing a lot of procedures. So there are nearly 250 plus real patient videos, like the one which I am going to show you after finishing the concept of internuclear ophthalmoplegia. So I have used the same technique. First, I am going to give you a theory. After that, I am going to show you a real patient, so that you are able to have a very nice theoretical and clinical integration. Right now, moving further, I am going to make a line diagram, and in this line diagram I'll be making the medial longitudinal fasciculars, parapontine reticular formation, all the things. So I want you to take pen and paper with me and draw it along with me, because once you miss it, which fibers are coming, where they are going, so you will not be able to reconnect the dots, right? Okay, so taiyar hai? Are you all ready? Okay, so let's start. So first and foremost is, we know that there is a frontal lobe. So anatomically frontal lobe is one, but physiologically it is divided into two parts. So I'll divide it into two parts. Physiologically, this is the right frontal lobe, this is the left frontal lobe. You are seeing from the front. Okay, now we have got two eyes. So this is of course the right eye, and this is the left eye. Okay, and the muscles which are moving the eyeball horizontally are medial rectus on the medial side, lateral rectus on the lateral side. Similarly, in the left eye, medial rectus and lateral rectus. ठीक है जी. Now the fibers which are coming from right side of the frontal lobe, they go towards the left parapontine reticular formation. So let's make it parapontine reticular formation. Don't worry, I am going to write it for you. It is parapontine reticular formation. Okay, now the fibers which are coming from PPRF, they are going to supply ipsilateral lateral rectus directly, but they are going to supply medial rectus of the other side, and before going into the medial rectus, they will pass through MLF, medial longitudinal fasciculus, MLF. Now they are going to reach medial rectus. So I am writing the full form of MLF as well. It is medial longitudinal fasciculus. Okay, now the PPRF of other side. So the fibers are coming from the left side going towards right PPRF, and similarly as of left side PPRF, so ipsilateral lateral rectus and contralateral medial rectus, but they will pass through medial longitudinal fasciculus. Okay, now if I make the eyeball move towards right side, both the eyes, so it will be contraction of right lateral rectus, there will be contraction of left medial rectus, that is dextroversion, and on levoversion it will be left lateral rectus and right medial rectus. Okay, what if there is damage to right medial longitudinal fasciculus? I'm just talking of right medial longitudinal fasciculus. So you go on for asking the patient to dextrovert. So right lateral rectus will be active, yes, and left medial rectus will be active. So both eyes are going to move towards the right side. But when you'll ask the patient to look onto the left side, so the left lateral rectus is absolutely normal. So left lateral rectus will pull the eyeball in abducted position. I am talking of left eye. So left eye is abducted, but because of damage to right medial longitudinal fasciculus, the right eye will not move onto the left side. So left eye is abducted, right eye is in the center. So there will be a condition which is diplopia, because left eye is perceiving some other view, right eye is perceiving some other view. So voluntarily I am trying to make my both the eyes go here, but left eye is going, right eye is not going. So it will send signal to the brain that okay, diplopia is happening. To undo this diplopia, the stimulus will come towards the left eye involuntary, and it will try to move the left eye towards the center to undo the diplopia. But voluntarily I am moving my eyes onto the left side. Involuntarily the left eye is being moved towards the center. So there will be a tug of war between the voluntary action and the involuntary action. So that is why we use the term in internuclear ophthalmoplegia, ipsilateral medial longitudinal fasciculus of the right eye is damaged. Now ipsilateral adduction defect. Adduction means movement inside, abduction is outside. So right eye is not adducting. Ipsilateral adduction defect with the contralateral horizontal nystagmus. Exactly, this is your internuclear ophthalmoplegia. Now if I may ask you, internuclear ophthalmoplegia is due to damage to which part? You will say, sir, medial longitudinal fasciculus. Have you understood this? So here let's see the image. So you ask the patient to look onto the right side. Okay, so right eye has moved right because of lateral rectus, the left eye because of medial rectus has moved right. But when you ask the patient to look onto the left side, so this is lateral rectus, but because there is medial longitudinal fasciculus damage, so there will be nystagmus. So what you call ipsilateral adduction defect. Adduction defect or deficit with contralateral means opposite side, horizontal nystagmus. Okay, all right, now I want to take it a little higher. Yes, okay, now what I do is I will give half score to each rectus muscle, horizontal rectus muscle. So lateral rectus receives half, medial rectus receives half, this receives half, this receives half. Now what if there is damage to the ipsilateral medial longitudinal fasciculus and ipsilateral parapontine reticular formation? Which muscles will go off? It will be lateral rectus, which is gone because parapontine reticular formation is supplying ipsilateral lateral rectus. Due to medial longitudinal fasciculus, the right sided MR is gone, but parapontine reticular formation was also supplying the left medial rectus via medial longitudinal fasciculus. But when there is involvement of parapontine reticular formation, how it is going to send the signal for the contraction of left medial rectus? So this will also be gone. Yes. Now if there is involvement of ipsilateral parapontine reticular formation and medial longitudinal fasciculus, how many muscles are gone? 3 muscles are gone. And what we had done, we had given half score to each horizontal rectus muscle. Yes, now 3 muscles means half plus half plus half. You typically call it as 1.5 syndrome. So 1.5 syndrome is due to involvement of ipsilateral PPRF and ipsilateral medial longitudinal fasciculus. Got it? Okay. Now I want to take it a little higher, just one line, and it will help you solving one more MCQ. There is another term, that is your 8.5 syndrome. What is 8.5? Nothing, nothing of very hi-fi sorts. Just remember, if there is involvement of 7th cranial nerve, which is your facial nerve, plus 1.5 syndrome. So you add it, because the facial nerve number is 7. So you do 7 plus 1.5. That is your 8.5 syndrome. That is involvement of 7th cranial nerve, which is facial nerve, along with 1.5 syndrome. That means along with the involvement of ipsilateral parapontine reticular formation and ipsilateral medial longitudinal fasciculus. Okay. Now in this video, we have done internuclear ophthalmoplegia due to damage to medial longitudinal fasciculus. We have done 1.5 syndrome, medial longitudinal fasciculus, parapontine reticular formation, and 8.5 syndrome, parapontine reticular formation, medial longitudinal fasciculus, to be topped up with 7th cranial nerve. I hope it is well understood. समझ में आ गया? All right. चलो अब in the end अब पेशेंट देखते हैं और आई एम श्योर यू विल बी एबल टू कनेक्ट द डॉट्स. देखें ध्यान से, देखिए क्या है. अब इसमें आप मुझे बस इतना बता दीजिए, which eye has got, which side has got MLF damaged. देखिए बताइए कहां पे है, which eye is involved, left eye और right eye. ध्यान से carefully check this out. तो बताइए. ओके, I hope that you have got it. So there is involvement of left medial longitudinal fasciculus. On asking the patient to look onto the right side, the left eye is not moving towards right, and there is horizontal nystagmus of the right eye to undo the diplopia. I hope it is well understood now. Okay, so boys and girls, this is your internuclear ophthalmoplegia. Yes, all right. So okay, so that is it from my side. Do give me your feedback. Do let me know how you like this video, and if you want me to do such more videos with clinical theoretical correlation, do let me know. I'll be happy to help you with it.